Good afternoon, all. I welcome all the participants, our guest speakers, Dr. Ashok Kumar Saxena and Dr. Sangeeta Sharma. I also extend my warm welcome to Dr. Srivastav, sir, Advisor, QPS Division, NHSRC. Today, we are conducting the 17th session of lecture series on standard treatment guidelines with the topics of unmet needs in pain management by Dr. Sangeeta Sharma and pain management in terminal care by Dr. Ashok Kumar Saxena, sir. As you are aware that today everyone are suffering from the pain management in one or other way. And it is very important to take the timely care and management of this pain. With this small intro, I request Dr. Jain Srivastav sir to address the participants and request to address the objectives of this lecture series. Over to you, sir.
Thank you, Anpurna. And at the outset, a very warm welcome to Professor Ashok Saxena, who took time out of his busy schedule to talk to us. And of course, I will be failing in my duty, but I don't mention the commitment and rather continued commitment of Professor Sangeeta Sharma over the years, who had been the force behind in continuation of this series, which is in the second year of its running. And of course, all the participants, your participation is important, and particularly for the esteemed faculty, Professor Saxena, that under this Health Wellness Center initiative, where the healthcare is being taken at the doorstep of the communities, and over there, lot of emphasis is there on the palliative care, and like not a qualified doctor, but a paramedical staff, they are supposed to be going, and we all know the extent of the problem which we have. I mean, the fact also remains that in our country, the pain management is something which normally is not gets its due attention. I mean, we all know that India is one of the largest producer of the opioids, worldwide opium, but our per capita say consumption of the narcotic drugs is one of the lowest. That kind of attitude that बीमारी है तो थोड़ी तकलीफ होगी, and particularly in the terminal stages when the person is undergoing lot of physical distress, emotional, spiritual uncertainty, and though in those situations it becomes a really challenging and grossly in fact under addressed problem. So without much ado, we are privileged to have you, sir, and I would request all participants, those who have joined from the either peripheral setups or the secondary care or even the tertiary care. See, this is one challenge as a medical practitioner we'll have to handle, maybe within the family setup or outside also in the communities where we live besides our professional say practice. So please do I mean attend attentively and ask questions. If you, I'm sure, I mean there would be many. So I'm stopping over here, and over to you, Madam Sangeeta Sharma.
Thank you, sir, for setting the scene here for the pain management, terminally ill patients. I think there are many misconceptions, beliefs surrounding around what is terminal care and what is palliative care, what should be done. Can I have Dr. Saxena's slide? Yeah. Because he'll be taking, so I have the pleasure of introducing Dr. A.K. Saxena. He is a professor of Department of Anesthesia at GTB Hospital. Formerly, he was head of the department also. He has 182 publications to his credit in both international and national peer-reviewed journals, and contributed immensely in various textbooks, 42 chapters. That's credible. He has been also a recipient of USA IASP Award for Excellence in Pain Research and Management in Toronto, Canada in 2022 during the World Congress on Pain held at Toronto, convention said. So I think he deserves a round of applause for that. And he is also a recipient of State Award from Government of Delhi in 2015. Over to you, Dr.
Thank you, ma'am. And thank you, sir, for the warm introduction. Learned audience, ladies and gentlemen, it's a privilege for me, to be delivering a talk on this particular topic, which is very close to my heart. And all of you know that, can I have the first slide, please? Right, thank you. So we can move on to the second one, and then we can move on to the third one also. Greetings from University College of Medical Sciences. Next one, please. Yeah, thank you. I would like to dedicate this talk to two persons. One of them is Dr. John J. Bonica. He was head of the department and director at Seattle University College of, or rather University School of Medicine, that is on the northwest frontier of the States. And his statement really carries a lot of meaning, that in chronic pain, because most of the time all these things pertain to chronic pain and cancer pain, that 1/3 of the population all over the globe has persistent or recurrent chronic pain. And by the way, all of you would be familiar with the fact that chronic pain actually is the pain which persists for more than 3 months. We call it as chronic pain. Sometimes, yes, for chronic pelvic pain, American College of Gynecologists say that more than 6 months, but on the whole, in general terms, we call it as more than 3 months. And imagine, out of these, 2/3 are either partially or totally disabled for number of weeks, number of months, or maybe sometimes number of years. Next slide, please. Now, this particular, next one, please. Next. Yeah. Now, the other person whom I would like to dedicate this talk is a very dedicated lady, who was actually initially a social worker, then a nurse, and then finally she got admission in UK in the St. Thomas Hospital. And initially, when she was joining as a nurse, her father was dead against her joining as a nurse in the profession, but then she was adamant. And she is famous for so many things, in the sense that the first and foremost is she's the founder of the modern hospice movement, right? Modern hospice movement, and hospices actually pertain to the palliative care, care for those terminally ill patients. And she established the first one at St. Christopher Hospice, which is there in the southwest of London. Those of you who would have gone there must have seen. And this is attached to St. Thomas Hospital. And she was the one that, actually speaking, I would tell you that she also suffered from a painful and slightly crooked spine. And for a certain number of months and years, she was made to lie flat on the floor for almost 40 minutes a day. That was the instructions passed on to her. At the same time, she was a committed Christian, yes, and she, squashed the notion. Please listen to me very carefully. She squashed the notion that the risk of opioid addiction was an issue in the pain management of patients, especially of patients suffering from chronic pain and cancer pain. So you see, when patient is in pain, will never develop addiction to opioid, even if you keep on repeating. But yes, if obviously Dr. Sangeeta is a master of this subject of pharmacology, the problem of addiction comes only when you are just misusing and abusing the drug, just like left and right. So she insisted that dying people needed dignity. She was the first one in the globe who said that dying people needed dignity, compassion, and respect. So imagine someone introduced and initiated this concept, and that's where everything took off. That's where the palliative care took off. She introduced the idea of total pain, and as Dr. Srivastava was saying, which includes the physical, emotional, social, and spiritual dimensions of distress that patient of chronic pain and cancer pain actually honestly experiences. So she, at the same time, yes, she was a committed Christian, and she died ultimately of breast cancer, right, at St. Christopher. She was admitted at the same hospice, And, that's what I said, that she always believed in the concept that constant pain needs constant control. Let us believe, this should be your take home message, that constant pain needs constant control. Please remember that. She was in between, as I was saying, at the age of 33, she was accepted as a medical student at St. Thomas Hospital in between, and that's her story. So the name goes on as Dame Cicely Saunders, rather the full name is Dame Cicely Mary Strode Saunders. We can have the next slide, please. Now, why palliative care she thought about? Well, today, dear friends, I'm sure you know that cancer is one of the leading cause of death in the modern world, right? With almost 8 million deaths worldwide. Maybe more also, I may be wrong, but minimum 8 million deaths because of cancer. And it is projected to rise to almost 12 to 13 million deaths by the time it is 2030. That means in another 6 year or 7 year, you will see the number of deaths will reach 12 or 13 million, which is such a large number. And unfortunately, most of the resources for cancer management, they are actually located in the Western world, in the high income countries. Whereas 70% of the cancer deaths actually happen in the low income countries and middle income countries. So that's why India is facing that challenge. Now, the development modern medicine in 20th century, largely ignored the need of terminally ill patients. But as time passed on, as I said, thanks to Cicely Saunders, that this concept came. Now, this is where you see she started the palliative care approach. And this is where you are seeing the main purpose was to alleviate the pain and suffering of those who are suffering from chronic pain or cancer pain. And finally, they also, they made a request to WHO, and WHO was also kind enough to actually issue those instructions. I would say issue those instructions for the establishment of palliative care units in various countries. So obviously, as you know, the thing started initially in the Western world. As I was saying, imagine the Department of Palliative Care as a specialty. It got established in UK. Along with that, USA also, that was in the year 1987. So the recognition was given in 1987, not before that. So this particular recognition has actually enhanced the development of palliative medicine all over the world. And initially it was under the auspices of Royal College of Physicians in UK, and they were giving 4-year specialist training under and through MRCP in palliative care, or an equivalent higher qualification, whatever it may be. So WHO describes palliative care as a very special approach that improves the quality of life of patients as well as their families. Please remember that. Not only of the patient, but as well as their families facing life-threatening illnesses, through the prevention and relief of suffering by means of early identification and impeccable assessment, which is very important. Yes, time to time, intermittently, you have to do regular assessment and treatment of pain and other problems, which may be physical, which may be psychosocial, which may be spiritual also. So please remember, can you go to the next slide, please, that chronic pain has been described as a biopsychosocial phenomenon. This is something very important for you to understand. Chronic pain is a biopsychosocial phenomenon. Now, why we say that? Because after 3 months, or say 4 months, 5 months, and maybe 6 months, you find that patients have a high degree of anxiety, phobia. Many of them go into depression. They are irritable, they are frustrated, and there is a kind of what you call it as kinesiophobia. That means they are fearful. They are fearful because of lack of confidence. If a particular limb is in persistent pain, they will not move that limb. That is what is kinesiophobia. So those things are there. So here you find that in palliative care, it provides relief from pain and all those associated distressing symptoms, and affirms life and regards dying as a normal process. All of us know, death is inevitable. Am I wrong? Death is inevitable. But we want that each and every human being on this planet to die with dignity, to die with respect. He should not die in pain. That is the ultimate crux of the matter, that we don't want the patient to die in pain, right? So it basically palliative care integrates the psychological and spiritual aspects of patient care. We'll talk more about it later on, and offers a kind of support system. It even helps in bereavement. Imagine, right? And I mean, you will say we have not seen, but then you will find that yes, in the coming years, and now the government of India's focus, and all states, and even the Indian Medical Association, they are laying a lot of emphasis on the establishment of palliative care services in each and every hospital. Next slide, please. So, WHO definition of palliative care, well, I've already described. Point here is that what exactly we are doing. We are actually treating the symptom. Always remember, the opposite of palliative care is curative care, right? Remember that way. We are not providing cure. Always remember, we are not providing cure for the underlying pathology. We are only a supportive system. It's a team approach. We are trying to address the needs of the patient as well as their families, as I said, right? Including the bereavement process, and which ultimately will improvise and enhance the quality of life. So just remember it that way, right? And it may also positively influence the course of the illness. Yes, I'll give you one example. I was there for my fellowship at Sloan Kettering Hospital in New York. You know, that's so famous for oncology. So I was there for onco anesthesia and for my pain management. Now over there, we had a sister in charge who was actually suffering from carcinoma of the pancreas, right? And this was somewhere around 97, 98. And then, and she had been given the time that she will not survive for more than 6 months, 9 months, something like that. But then what happened is that when I inquired, on my next visit, I found that she ultimately died in 2004. So imagine that simply because she was provided with, all the nitty-gritties of the palliative care system, a team approach, which actually enhanced her quality of life. And she died in peace in 2004, right? So you'll find that in the course of illness, in conjunction with other therapies like radiotherapy, chemotherapy, which are intended, to actually cure, right? Hopefully, yes. So along with that, this supportive system is provided, right? So this is something which, uh, uh, what is palliative care, which goes along with all those things, and even when everything has been done, and you find that patient is still in pain, and that is where then you find that there is an important role for palliative care. Next slide, please. So you know what is the goal? I've already mentioned you, right? You are trying to enhance the quality of life. You are providing enormous assistance to the patient as well as to the family members, all right? But please remember that this palliative care is not there only for terminal cancer pain. Always remember, it is also there for some of those neurological ailments, right? Very advanced stages, terminal stages, even for patients in advanced heart failure, even for patients in very advanced COPD or chronic obstructive pulmonary disease, which is actually a systemic disease, or as I said, progressive neurological conditions, and even in advanced renal failure, right? Where even if the renal transplant has been done or patient is on CRF, but he's going down and his condition is deteriorating. So there also comes the role of palliative care, all right? So it's a teamwork, right? And we are providing assistance. Please remember that it is in stages, right? If I say stage 1 of palliative care, stage 1 of palliative care, actually, it means that the patient, the family, and the healthcare team, right? They are working together to devise a plan for end of life care that prioritizes patients' remaining quality of life. Am I right? So when I say patient, family, and the healthcare team, they are working together. And along with that, please remember, there are social workers also, and they're chaplains. Right? Chaplains are, अगर आप उसके हिसाब से चलते हैं, this is mainly according to the Western world. Here you have, if we plan it that way, we can have the priest, we can have the pujari, and all those things. They will provide spiritual and emotional care for patients and their families. right? I was there, that was again in 99 when I was there in Scotland, one of the hospices. So over there, what they used to do that they had divided days. Like Monday, they will, patients who are Christians, they will call the priest from the church. Or if they're Hindu patient, then they will, on Tuesday they had reserved the pujari, and Muslim patient from the mosque. And like that, they had devised days, even from the Gurudwara, one of the Thursdays or Fridays that that saintly person used to come. So please remember that these are the things which are there. Now, what are the? Can I have the next slide, please? Now, history, as I've already told you, right, that the whole thing started mainly in the late stages, in the later years of 20th century, right, and uh, started from mainly again, yes, here from London and Ireland mainly, and it initially began as a volunteer-led movement. Imagine they used to volunteer; they were not getting any emoluments or any salary, right, and then the movement spread. Next slide, please. Now. Palliative care versus hospice care, as I said, the hospice is a very special kind of infrastructure which is there, right? And it is actually a type of palliative care for those who are actually at the end of their life. Always remember that, right? So division made between these two terms in the United States basically, and both the services, they have foundation on the same philosophy, actually speaking, on the same philosophy. And that means the reducing the severity of the symptoms, right, of a sickness at any age, remember, right? I should not say only in the old age, but even the pediatric age, a lot of research is going on. Okay. Now, who receives palliative care? As I said, individuals struggling with diseases, individuals with chronic disease, such as, as I said, including those HIV patients, Alzheimer's, and amyotrophic lateral sclerosis or ALS. Next slide, please. So, who provides? I told you already, there are doctors, there are nurses, there are social workers, right? There are spiritual experts, right? Those saintly persons, there are pharmacists, nutritionists, physiotherapists, psychologists, and several social workers and volunteers, right? Next slide, please. So, patient and the family, right? They, their care, it encompasses uh, in a circular fashion, including all those 4 dimensions which I've mentioned, and all these things which I've already told you: the doctors, the nurses, the pharmacists, and the social worker, etc. Next one, please. So, chronic pain, please remember that chronic pain, as I said, and this means the cancer pain also, it has got cognitive aspect, it has got sensory discriminative aspect, and it has got affective or motivational aspect, right? So ultimately, because they get compromised, that is why there's impact on quality of life, and then comes pharmacogenomics, right? Whatever therapy you are using, the response may vary from one patient to another. Dr. Sangeeta knows it very well, the different genes for different phenotypes, and then there is also gene environment interaction also pertaining to the underlying pathology. Next one, please. So the when this is, of course, I think we can move this, one of the meeting where we had attended. Next one, please. And yeah, next one. And palliative care people also face challenge, and you should be ready. I expect you to be ready to face challenges of life and challenges of the aberrations in the behavior of such patients. Messi is the typical example. He has faced challenges, and you can see he's a global figure. Next one, please. So, comprehensive pain assessment obviously is required at repeated intervals, right? As I said, there are 4 principles of palliative care. Please remember, care is, we are giving is patient, family, and carriers. The carer centered care provided is based on assessment always. Care is evidence based, always remember. And the patients, families, and the carers, they have access to the local and network services also. Please remember that. That's very important. Okay. So when you're assessing, what is the onset, what is the duration of pain, and what are the aggravating factors, what are the relieving factors for pain, you must remember, right? And it can be mild, it can be moderate, it can be severe, or it can be excruciating pain. Always remember Okay, that's why we have a 0 to 10 scale. 0 means no pain, 0 to 3 is mild pain, then 4 to 7 or 4 to 6 you can say as moderate intensity pain, and then 7 to 9 will be severe pain, and 10 out of 10 will be actually excruciating pain. So please remember that, right? Okay, the next slide, please. So total pain. Cicely Saunders, that lady, again gave the concept of total pain. That contribution also is very significant. It's a total pain. That means you have the, if I say PAIN, you find P for physical symptoms, and A is for, as I said, anxiety or even associated depression may be there, right? And, they have that feeling of frustration, hopelessness, right? And they have suicidal tendencies. Please remember, that's again a big problem with such patients, right? They may have, obviously, because they have lost their job, so they have those kind of personal issues, and no support system, no financial support for the family, right? And so we have to understand all this, right? And then you have non-acceptance of the approaching death. That's another thing, you see. That is why, you see, one has to be prepared. Everyone should be given these teaching that you never know when we may have to go up. But then there are people who have not accepted this fact even till late 80s or 90s, So that's a big problem, right? Non-acceptance of the approaching death. That's not a good approach. All right. Next one, please. Okay. So I have already talked about the assessment part, right from history, and patient might already be having some investigations. We always go through that. Say lab, MRI. Say MRI. Say patient has been having chronic low back pain, or there's metastasis in CA prostate or CA ovary, and their vertebral body, the metastasis is there. Patient is having severe bone pain. So you have to have MRI. You have to have PET scans. All those figures we will really tell you, and you will narrow down to a particular diagnosis, right? So thorough assessment is required. And at the same time, as I said, the psychological assessment is also needed, which includes tools like, HADS or Hospital Anxiety Depression Scale. You also need to assess for neuropathic pain using, of course, paucity of time, I cannot talk about them in detail, but please remember there is a DN4 questionnaire, which is a French questionnaire. You have NPSI, neuropathic pain symptom inventory, and you have PDQ or pain detect question. So when I say neuropathic component, you see, 1/3 of the patient of cancer pain will have neuropathic component. 1/3 will have a nociceptive, or what you call nociplastic component. And another 1/3 will have mixed. That means both neuropathic and nociceptive. So please remember it that way. And which one we say neuropathic pain? That means if patient has been having, those burning, tingling, burning and stabbing and lancinating kind of sensation. Real burning and stabbing sensation. As if someone has shot a kind of bullet in the arm, right to the nerve, and that's where you have the CRPS, right? CRPS type 2, or those kind of syndromes which are there. So please remember all that. Next one, please. Right. So we have detail, as I said, psychosocial, spiritual assessment using for psychosocial. Yes, we have, as I said, HADS and back pain inventory, all those kind of things. And so these are the things, previous experiences also again, and what kind of coping mechanism patient has been adopting, that also matters a lot. And psychological symptoms I've already told you, which includes the suicidal tendencies also. Next one, please. So psychosocial and spiritual assessment having been done, and that's where you find they need to know the meaning of pain and suffering and retribution. And many of the patients think that it is their karmas, and because of those karmas, they are getting this punishment. We need to actually counsel them, right? Then in the social and relational issues, again, human relationships are is a very big issue, and you'll find that when patient goes into terminal stage of cancer, many of their near and dear one also stop meeting them. So that's a very unfortunate part. So there's an important role for the family. The physical appearance changes. Obviously, we know there's immense burden on the family. Next one, please. Yeah. Cultural issues, very important. Yes, it varies from one part of the world to another one, but cultural issues are also very important. What kind of local cultural factors which are there, and we need to assess that, and we need to build trust. That is very important. We need to build trust with the patient as well as their family members. That's very important, right? And but one should always try to know more about their cultural background, cultural beliefs, and the practices that they have been doing. You see, there may be someone, like, if I give you example of uh, Lord Rama's follower, another one may be a Hare Krishna follower, right? And then, it may be that they want their, the Krishna priest to be there, or they want the Rama priest to be there. Those kind of things are there. So we need to know all that so that we can counsel them and get the help of those kind of pujaris, right? Next one, please. Right. Next one. So then there are always myths, and you need to really demystify them. The dying is always painful. Those kind of things are there. You can't deny. If you talk to any common man, and even some of those who are in elderly stage, they will always say dying is very painful. And some kinds of pain can't be relieved. It is not right. But yes, I would say there are one or two which are very challenging, like central pain syndrome, thalamic pain syndrome. They are very challenging. But even then, there is a cure for everything, but not to that extent. But if cure is not there, you have the supportive system, palliative care. So those kind of things are there, and they need to be told that yes, there are medications which can take care of their underlying experiences. Right. Next one, please. So the pain myths continuing that only injections give you good pain relief. That's a very big myth. Please remember here that when I'm talking about palliative care, all of you should know that there are oral morphine tablets available. Please remember that. I know oral morphine tablet you will not find in a chemist shop. You will just find maybe those who have license. Say in the city of Delhi, just about 4 or 5 chemists are allowed to keep oral morphine. Otherwise, in institutional practice, yes, oral morphine is allowed. And nowadays, following that Act of Parliament, which was passed in 2014, now the excise rules have also been made more flexible, and there are not so much of tight regulation. But yes, we need to, if my institution or my department has been given oral morphine license, then we need to maintain a record. It should not be misused. It should not go into those hands where, those kind of people who are trying to misuse it. So that should not happen. But yes, record has to be maintained. That's important, right? So oral morphine, we must know that it is there. If I say some of the drugs which are there, we can forget morphine for the time being. Say midazolam. Midazolam, is another drug which has been used, and this midazolam can also be given subcutaneously also. Then also you will achieve faster, I should not say pain relief, for midazolam for the high degree of anxiety. Again, it will act very fast. Okay, so different routes can be adopted, but yes, intravenous one is quite fast. But with drugs like midazolam, intravenous, subcutaneous, both are fast. So please remember that. And during pain and suffering can enhance one's character. It doesn't happen that way, but there are people, yes, who have high pain threshold, but then not everyone has that. And once they start giving you morphine, the end is near. So that should not be the concept. As I said, it is not like that. People have to be in hospital to receive effective pain management with morphine. No, it is not that. We get not many patients at GTB hospital who travel all the way, 50 to 100 kilometer or even 150 kilometer, and they get their full quota of oral morphine tablet, and then they come back again after 2 weeks or 3 weeks to continue the therapy. All right. But then we have interventions also. We'll talk about it later on because time doesn't permit me. Right. Next one, please. So this is where the pain scales are there. We were talking about visual analog scale. We also call it as NRS, or numeric rating scale. For pediatric, for pediatric people, there can be pediatric malignancy also although they are very low in incidence. We have the facial scale. Please remember, right? Where the child cannot actually give you those figures, you have the facial expressions, right? But then, as I said, you have neuropathic component, and you have other scales also, which I was talking about as HADS or NPSI or DN4 questionnaires and scores and all those kind of things. Now, what does WHO say? It's a step ladder approach, right? And in this particular one, the top one where I have written pain free, it is actually, it has been replaced. That I'll tell you. So the longer base, bigger base, biggest one, you have the non-opioid plus adjuvants. Which adjuvants for pain? Like you have amitriptyline. Now amitriptyline, is not only a tricyclic antidepressant, but then it also, it increases the level of serotonin in the brain, and thereby it activates and stimulates the descending inhibitory pain pathway and stop the incoming pain, noxious painful stimuli. So those are the adjuvants, right? You can have other adjuvants also. You can have clonidine, you can have dexmedetomidine, right? Alpha 2 agonist. Okay, but the biggest one is amitriptyline. All right. Then mild to moderate, you'll find that you can have, weak opioids, right? You can see the second one from the bottom. Weak opioid is tramadol, right? Please remember, weak opioid is tramadol. Now there's another category on top of this, which is moderate to severe pain. And you find for moderate to severe pain, now we are switching over to oral morphine. Remember that, okay? But you see, if a patient of advanced cancer has come to the casualty, or say in the pain clinic, and you find that he has never received oral morphine and he's in severe pain, we categorize it as say 8/10 or 10/10 or 9/10, then we should be giving and administering intravenous morphine. So please remember that way, okay? Otherwise, yes, if he's maintained, and how is maintained on oral morphine, we'll talk about it later, but please remember, they are available in the Indian setup. They are available in the strengths of lowest one is 10 milligram tablet, okay? 10 milligram, and then we have a sustained release 30 milligram. And then we have even 60 milligram sustained release oral morphine tablet, okay? But when patient of cancer pain lands up with us, we make a beginning with a dose which is 4 hourly, remember, 4 hourly administration of morphine at the rate of 5 milligram, okay? 5 milligram every 4 hourly, okay? It comes to 30 milligram per day. But now next visit patient comes and finds that yes, the relief is inadequate. Then we increase it to almost 10 milligram 6 hourly, which becomes 40 milligram a day, okay? Again, next follow-up patient still doesn't have satisfactory pain relief. Then we increase it to almost 30 milligram, right? 30 milligram BID, which comes to 60 milligram per day. Even then, if it is on next follow-up not relieved, we can make it a 60 milligram BID. When I was there at Sloan Kettering, and even here also, but not many over there, many of the patients were receiving almost 600 to 800 milligram oral morphine per day. Remember that. Some of them even have received 1 gram or 1000 milligram per day, quite high. And even then, they never became addicted. Even then, they never had respiratory depression. Please remember that. Okay. So these are the things we do. Now, the top bar where is pain-free. Now we have interventions. And that is where, as a pain specialist, our important role. Like if I get a patient of carcinoma of the stomach or carcinoma of the pancreas, I have the skill and I have the tools and the gadgets to administer and provide a celiac plexus neurolysis, a celiac plexus block, whether under C-arm or it may be under ultrasound guidance or it may be under CT scan guidance. Okay, celiac plexus, celiac plexus is located at the level corresponding to lower border of T12 and upper border of L1. Okay, patient lying in prone position. But for USG, patient lies in supine. So these are the things you need to remember. Similarly, for patient of carcinoma of the cervix or carcinoma of the carcinoma of the testes, you find, or carcinoma of the ovary, you have another block which is superior hypogastric plexus block, right, which is located at the level corresponding to lower border of L5 and upper border of S1. Okay, so that way you can remember. You can do it again under CM or under ultrasound guidance. Okay, so these are the things which you need to know. Time doesn't permit me, but another patient may be having chronic persistent perineal pain. There's persistent perineal pain because of metastasis. The whole thing from the rectum, from the scrotum, or from the ovary, everything has spread to and whole of the perineum, it is burning. There we have another approach which is known as a block of the, what do you call it? Walther's ganglion. right? It is the last sympathetic ganglion located at the sacrococcygeal junction, remember, right? And that relieves the pain, the perineal pain, like anything. Okay. Yeah, we can have the next slide,
Sir, we
please.
have time. You can take, we have session up to 5 o'clock. So no problem.
Okay, okay, okay. All right, ma'am. Okay, okay. Thanks. So the next slide, please. Now there are 5 basic concepts, you know, for oral morphine administration in a patient of cancer pain, in palliative care. And as you can see here, by the mouth, by the clock, by the ladder, for that individual, and with attention to details, means all those side effects you must monitor. That's very important. As I said, oral morphine, when you're using, the biggest problem is that of pruritus, and the second side effect is constipation, and third one is nausea and vomiting. Addiction is not a problem, as I said. So pruritus, that means you will have to take the help of your cetirizine, levocetirizine, and those kind of things. For constipation, yes, you'll have to be guarded, and you can take the help of all those different kind of like lactulose, or if not helping, then you can have your say cremafin type of these things, cremafin pink and all those kind of things. They do help, right? So, but it's a problem, definitely, and you can't ignore it. And nausea, vomiting, naturally you will have to use your those either pantoprazole or rentadine and those kind of things which are there. And by the WHO letter, that letter I have already described to you. And for the individual, very specific for the individual, please remember, like if I give you example, that patient whom you were trying to administer oral morphine, when morphine is metabolized, it gets metabolized into morphine 3-glucuronide and morphine 6-glucuronide, M6G and M3G. Now what happens? Patient already has renal shutdown. So if patient already has a renal shutdown, and M6G and part of M3G, they are excreted, eliminated through the kidney, and there is a renal shutdown. So those kind of underlying and that background, you have to be very careful. You will have to modify your dosage. Please remember, right? You can have mild renal dysfunction, moderate, or you can have severe degree of renal dysfunction. Okay. Similarly, you may have another setup where you have hepatic dysfunction, mild hepatic, moderate hepatic, or severe hepatic dysfunction, because most of the drugs are metabolized in the liver only. So those are very special instances when you will have to give a thought. You'll have to give a thought that what should I do, right? I'll go on to another example I'll give you, is that of midazolam, right? And as I told you, that for morphine, again, I'm repeating morphine, but then in the Western world, you have diamorphine also available, you have oxycodone also available, and you have L-fentanyl, right? But in India, we have been using either tramadol or morphine. But I told you, tramadol is a very weak opioid. It will actually be effective mainly for the mild pain. I can say a little bit about mild to moderate also, but not beyond that. And in our country, patients who don't get screening, majority of the population, so they'll end up with that kind of, they'll end up in the advanced stage, right? When actually tramadol will not be working. Okay, but what about drugs for breathlessness? In such a patient of cancer, you should have drugs for breathlessness also. Remember here. Now, the best part is that for breathlessness, we either in palliative care, we either give midazolam or rarely opioid for breathlessness. But midazolam is very good. Always remember. And so that means you should know a little bit about midazolam also. All right. All of you would be familiar that midazolam is a very special benzodiazepine, which is a sedative, which is anxiolytic, and which has anticonvulsant properties also, but not a true anticonvulsant. Levetiracetam is the true anticonvulsant, but it has got some meaning, and it's faster onset and shorter duration, much shorter compared to diazepam and lorazepam. So remember here, right? So midazolam is one which is very good for in the palliative care setting. Its metabolism also occurs in the liver by cytochrome P450, and that when you are talking about midazolam, it is actually acting on that particular the interface of the alpha and gamma. subunits of the gamma aminobutyric acid receptor. We call it GABA receptor, GABA A. Okay, it works on that interface of alpha and gamma subunits, right? Which they are very beautiful receptors which actually mediate the inhibitory function in the human brain. All right, so that is what you need, and that is why you're using midazolam, because it has a very high affinity to these GABA A receptors in the human brain. All right, and GABA A, actually consists of alpha 1, beta 2, gamma 2, those kind of subunits. And but benzodiazepine, they typically have affinity for that particular interface. That means alpha and gamma interface, which ultimately leads on to anxiolysis, right? Sedation, little bit of muscle relaxation also, and little bit of anticonvulsant action. So you are achieving 4-5 things only with the help of midazolam in a patient, who is actually admitted in palliative care setting, right? So this is one thing which you should remember. And as I was telling you about midazolam, that when I give it intravenously, right, it acts just within, what should I say, within 1 to 2 minutes only. Okay, when you give it subcutaneously, then also it is rapidly absorbed just within 2 minutes. So that's the beauty of midazolam, right? Intramuscular also you can give. I mean, it's very surprising that intramuscular midazolam also acts very rapidly. Onset is within 2 minutes. No other drug will act so fast because it has a very, very rapid absorption. If you ask me the half-life, it comes to around, midazolam has, there are two: distribution half-life and elimination half-life. The distribution half-life of midazolam is around 6 to 15 minutes, 1-5. But the elimination half-life is in hours. That means 1.5 to 3 hours. So that you should remember. And actually, if you clinically see, the duration of action of midazolam is 1 to 2 hours. That means 60 to 120 minutes. Okay. Even if the elimination half-life is almost 3 hours, but the duration is usually around 2 hours, and then you have to repeat. So you can repeat it, no problem with that, right? So, and so that's what I was saying. You are not getting a wean, give it subcutaneously. You can give it intramuscular. And if nothing is possible, you can give it intranasally also. When you push it intranasally, midazolam, it takes almost 10 to 15 minutes to act, right? So those are the things which you should remember. But obviously, midazolam, we don't have any oral preparation, so I can't talk about it. And it is good drug, but a little bit in those geriatric patients, in those in 80s and 90s, the clearance decreases in the elderly. So that we have to remember, right? Because liver blood flow decreases with age, and those kind of problems are there. In neonates, again, you can use it. Yes, no problem. But please remember that because neonates, newborn babies, the hepatic enzymes are immature, so that problem may come. So we must remember all those kind of things. And it's a very good drug. It has some kind of interaction with H2 blocking agents and those kind of things, right? They can influence the metabolism of midazolam. You can always combine midazolam with droperidol. Remember here, right? Or even olanzapine. This is a treatment option for palliative care patients who are highly agitated in the emergency room. Please remember that. Okay. So again, you have the role of midazolam in combination with either droperidol or olanzapine. Okay. So that's one thing. It has role in the management of breathlessness in cancer patients, and where also opioids are useful for the treatment of terminal dyspnea, because they are again you are elevating the anxiety which is associated with dyspnea and all that. And seizure, yes, I told you that it has some amount of anticonvulsant action, very mild analgesic action, and helps with insomnia. Patients who have not slept, again midazolam will help. And delirium, agitation, I've already told you. And those kind of things are there. When you are using a continuous infusion, it is also effective in refractory pruritus. If you have used morphine and you're finding that your levocetirizine or cetirizine is not helping, midazolam will be of immense use, right? But you'll have to give a bolus followed by infusion. So that is something which you should remember. And if your patient who is in palliative care setting has some kind of muscle spasm, right? muscle spasm and spasticity, where sometimes we use baclofen, sometimes we use agents like clozoxazone, or sometimes we use metaxolone also, right, in combination with diclofenac. But here, even midazolam can be used to relieve those muscle spasm also, right? So it is one of the benzodiazepine which is of immense use and has a rapid onset and is very safe. All right. So please remember the beauty of midazolam, right? So the next slide, please. We go on to again when to use opioid. As I was saying, uh, uh, truly written here that when patient has severe pain, that means 6 out of 10 or 8 out of 10 or 7 out of 10, then yes, you will need morphine, right? But as I said, if patient has mild pain, that means 4 out of 10 or 5 out of 10 on the scale, then you can use tramadol also. All right. So it's like that. But you need to titrate the dosage, and I already told you that there's no upper limit on the dosage of morphine on a daily basis, right? But do not delay, for God's sake. Do not delay the treatment. But yes, one thing you must remember, and even we have failed on many occasions. What is it? Because obviously, we are working in a government setup, and things are not in our hand. Uh, you need an uninterrupted supply of oral morphine at every cost. Now, it is very easy for me to say that you need an uninterrupted supply of oral morphine. But sometimes you find that your pharmacy people, your drugstore people will say, like, sir, morphine is not available. You will have to wait. It is under processing your order. So those kind of things we have to face. And poor patients, our poor patient cannot afford it, cannot buy it from outside. That's a big problem. So that thing you must remember. The other thing you should also know, which I've not brought that slide over here, it is on transdermal patches, right? Transdermal or a matrix technology, right? The transdermal patches are very effective, but then they are very costly also. Those patients from well-to-do families, yes, we are able to advise them, and they take transdermal fentanyl patch, right? That fentanyl patch, which comes in the strength, which releases around 25 microgram hourly basis or 50 microgram hourly basis, right? And it has to be changed every 72 hours. At the end of every 72 hours, the patch has to be changed. Okay. The other one which is there in Indian market is transdermal buprenorphine patch, which we have been using. Again, very expensive, but it comes in 3 strengths. That means 5 microgram, 10 microgram, and 20 microgram, right, on an hourly basis. And those are again, but buprenorphine, that particular patch has to be changed only at the end of the 7th day. At the end of the 7th day, that transdermal buprenorphine patches will be changed and a fresh one will be applied. Right? But other things remain the same, like transdermal fentanyl has been used, or buprenorphine, high degree of nausea, vomiting, which you have to take charge, and you have to assess the patient and keep assessing regular basis, right? Next one, please. So narcotic routes, I've already told you, right? I've told you that those things, I think we can escape and go to the next one. And starting route, as I said, is always when patient is in severe pain. Giving oral morphine obviously will take time, so you should give intravenous. The intravenous morphine may be what you're giving in aliquots. You may be giving, patient 60 kg or 70 kg. You may be starting with intravenous 3 milligram morphine, right? And or maybe you can repeat it also, but you'll find it is of immense use in such patient. If the initial score was 7/10, after giving intravenous morphine, it comes down to 1/10, or maybe 0/10, right? It all depends on the underlying condition. But for patients with mild to moderate, I would say even moderate to severe, we usually give oral morphine. Okay. And that's why we try the oral one first, right? But intermittently, sometimes the compression is there and the pathology that changes its position, then we may have to give intravenous also in between. Next one. Now, learn the patient's pain score, patient's pain goal. Yes, I told you, reassess the patient's response. And also you should know, yes, there may be many patients who are already taking some amount of opioid, and on top of that you're prescribing this one also. So that may also happen. Okay? And like that. Yeah, next one please. So you have a typical presentation here. This patient was opioid naive, never on opioid, metastatic ovarian carcinoma. Okay. Now this is where you find the pain score actually was 6/10, and patient has been eating and drinking normally, no problem. We have started oral morphine, right? This is what you find here, right? It is written as 10 to 15 milligram per day, but actually speaking, it was 10 milligram. It was 10 milligram 6 hourly. Okay, that means 4 times a day. That comes to 40 milligram per day. And then pain score, obviously, you see, the satisfactory pain relief in chronic pain and cancer pain is not 100% pain relief. Always remember, you have to tell the patient that I'm targeting only for 50% pain relief in your condition. Don't expect more than that. If you get 60, 70, 80, or 90% pain relief, you're very lucky, and it's a bonus for you. So that way you must say. Otherwise, we go by the law of expectations. Always remember, if your patient's expectation is very high and patient wants 100% pain relief, then you'll have to counsel him. So most of the patients do understand, but many of the patients in our busy practice, we tend to forget that this particular thing also has to be told to the patient. So in the next visit, follow-up visit, patient will say, "That's I never got 100% pain relief or even 90%." So because they were expecting. So the law of expectation is very important in your life. It applies for so many things. Okay, right. Now the pain score, so it got changed, and ultimately, of course, this particular patient that I was talking about, right? We had to increase the dose, and finally, a patient was administered superior hypogastric plexus block, right, as I was telling you, which is a retroperitoneal structure, and just behind the bifurcation of the common iliac artery, right, and that is where we take our needle and use our absolute alcohol or 95% alcohol for neurolysis, and it provides relief for almost 6 to 9 months, sometimes 12 months also, and sometimes it may be 1.5 years also, 15 months or 18 months. And the remaining period of patient's life, with especially with metastasis and all that, you'll find that, yes, at least they are able to remain comfortable. The only thing where we are failing actually is because a lot of research is going on, is with the bony metastatic pain. Bony metastatic pain. Patients of CA prostate, when it is sitting in the vertebral body, that metastasis. Recombinant gene therapy has been there. Other things which are also there, but in the initial stage, not in the advanced stage, in the initial stage, you can also use bisphosphonates like zoledronic acid. 4 milligram intravenously infusion over a period of 15-20 minutes, and then patient can go home and is called back again after 20 days or 3 weeks almost, right? So those kind of bisphosphonates can be given, but please remember side effect. Every drug has side effects. Similarly, the zoledronic acid can always produce, important side effect is osteonecrosis of the jaw, which we have seen, osteonecrosis of the jaw. So please remember that. Okay. Similarly, for if patient comes in late stages, you can use those osteoclast inhibitor, right? So those can also be used. So bisphosphonate or osteoclast inhibitor accordingly, right? Next one, please. Next one. So the next one is the next slide, please.
So this is the next one. On
this
opioid. The earlier one was opioid naive.
Right. Oh, I'm so sorry. Yeah, that's right. Yeah. So this is where you find that yes, initially we had to increase the dose, and then you find by almost 50%, then you reevaluate, and pain, then it was going down. That means the relief was more than almost 50% relief, and you find that at this stage, as the side effects and those pruritus, etc., had increased, the constipation also was there, and we had to overcome with all those kind of adjuvants which are there. Another one which is there actually is oxycodone, which is again not available in India, But please remember here that you must be familiar with the epidemic of opioid overusage in US. So that was some kind of uh, malpractice which actually happened in certain centers in 2016, of course. So uh, they were prescribing too much of oxycodone and those kind of drugs, and for their selfish reasons, whatever I can say. But now with the tighter control, the doctors are not doing that, and morphine, yes, remains the basic opioid for management of this cancer pain. Next one, please. So score pain 7/10, and you find that opioid naive. As I said again, same way, you have to give intravenous morphine, right? You may 5 milligram intravenous in one go. I've never used, and please don't do that, because these figures of 5 milligram are mainly for the white race or the Caucasian population. But our Asian population, usually 2 to 3 milligram intravenous is quite good, though it may be short lasting effect, but even then it is good. And continue this effective dose. You can repeat it. I won't say 3 hours, but every 4 hourly, yes, you can repeat it. And even then, if you find that relief is not satisfactory, you can double the dosage, right? And keep reassessing every 15 minutes instead of half an hour. And accordingly, you can titrate your dosage. Okay. One word about PCA, or patient control analgesia. PCA you will not find so much in government setup, but though it is not very expensive, this PCA equipment cost is around 1 lakh, because this is where the patient has a knob. Patient can simply press on the knob and the bolus will be delivered. But then it has a lockout interval also. That doesn't mean patient keeps pressing every 2 minutes and keeps getting the dosage, because if you set a lockout interval around 30 minutes, so even if patient presses, the drug will not be delivered. Okay, so that PCA is patient control analgesia, but the satisfaction of the patient is very good with PCA. So those kind of things are there. There are merits and demerits also. Yeah, next one, please. Thank you. So this is another patient. You calculate total IV morphine dose taken over the last 24 hours, and then you have 20% of it. You give it as bolus. Reassess the patient in 15 minutes. Pain relieved. Then continue the same dosage every 4 hourly. All right. But unrelieved pain, then you got to repeat initial dose, reassess. If unrelieved, give double the dosage. We were already talking about that. Okay. Next one, please. Continuous infusion. As I said, yes, your patient is admitted and is under good care, where you have the syringe, because you need syringe pump for continuous infusion. And many times in government setup, the syringe pump may not be functioning, but then a good setup, yes, it will always be functioning. And so bolus followed by infusion, and you're titrating the infusion, definitely, right? You may be giving almost 8 milligram, say, every 4 hourly, or 2 milligram every hourly, like that, because 2 milligram on an hourly basis, that comes to 8 milligram in 4 hours. So like that, you can always see that lockout interval, how much you can keep 4 hours also, right? So accordingly, you can calculate that how much has been the dosage delivered in 24 hours. And again, same way, morphine 2 milligram hourly basis, you titrate by 1 milligram every hourly, every 15 minutes, severe pain, or on dyspnea, or every 30 minutes, accordingly you can. So you can titrate it accordingly. Yeah. Next one, please. So as I was telling you, that morphine is available, right? And very easily available, and plenty of routes. All those routes are there, and you can use them. Okay. And as I told you again, renal failure, metabolites will accumulate, M3G or M6G, right? Nausea can happen, and itching has to be controlled accordingly. And constipation, again, as I said, prevention is important, and all those kind of modalities are available. Yeah. Next one, please. So choice of opioids, I said in India you don't have much choice, right? The if I say hydromorphone, again not available in India. Oxycodone, not available in India, right? L-fentanyl, again not available in India, right? And the fentanyl one which you have, although it is 300 times as potent as morphine, please remember, fentanyl is very potent, but then fentanyl is lipophilic in nature, and morphine is hydrophilic in nature. So if I'm giving an epidural or an intrathecal in the neurexal area in the spine, I can expect, because we have been giving, but patients are admitted and we are monitoring. And if I'm giving intrathecal morphine, that means in the spinal subarachnoid space, I'm pushing morphine that can travel up, remember. It can, आपने lumbar level पे दिया, it can reach up to thoracic level. It can cause respiratory depression. That way, not otherwise, not with oral morphine. And when you give intrathecal morphine, especially the subarachnoid morphine, you can have early respiratory depression, right? You can have late respiratory depression, as late as 16 to 18 hours. So please remember, that particular rule, yes, respiratory depression may be a problem, but not with oral morphine tablet. Always remember that, okay? And then we go to the next slide, please. Yeah. Again, continuing with this, and I talked about the patch, okay? And in the patch, you have two in India, fentanyl patch, and the other one is your buprenorphine patch. Please remember here, right? I told you it is perfectly US FDA approved. No problem with that. But always remember that it should ideally not be used in opioid naive patient. You have given oral morphine, and then it was not suiting, so you have to switch over from oral to transdermal. Always remember here. And always the formula here is that 100 milligram of oral morphine is equivalent to that fentanyl patch, which delivers 50 milligram of fentanyl on an hourly basis. Okay, I told you it comes in two sizes. One which delivers 25, another which delivers 50 microgram on an hourly basis. Okay, so these are the things. Yeah, next one, please. And methadone, yes. Somehow methadone has been cleared by Drug Controller of India, but then it has a very long half-life and it's very potent. And there are one or two important side effects also. But for neuropathic pain, yes, methadone may be a better choice. But even then, morphine is all right. And methadone is a good choice for patients with opioid tolerance. That's important. With high doses, patient can develop tolerance to opioids, right? So then in that case, methadone is a better drug. That you should remember, right? Next one, please. And there are about, those misconceptions. The biggest one I told you, the addiction, which is a problem. Okay. And I think otherwise, oral morphine will never cause respiratory depression. Always remember that. Those kind of things are there, but mainly that tolerance can develop, definitely, sometimes. Right. Next one, please. There are, I think we can skip this one, right? And the next one you have the prevent the constipation. I told you, you got to manage some of the unwanted persistent sedation. Naturally, patient will be drowsy all the time. So those things are there. And that's it, I think. Yeah. Next one, please. So we have adjuvant therapies. I was telling you all those kind of things. Yes. Yeah. This is important. You see, when I was talking about neuropathic pain, how we define neuropathic pain as pain caused by a lesion or dysfunction of the somatosensory system. That you should remember. That is what is neuropathic pain. And I told you 1/3 of cancer pain, the component of neuropathic pain will be there. And for that, you have alpha-2 delta ligands. Alpha-2 delta ligands like gabapentin and pregabalin. Always remember. Gabapentin and pregabalin are like the mother and father of all the drugs used in neuropathic pain. The difference here is as compared to Caucasian population, if you read those textbooks, you'll find upper limit for gabapentin is 3600 milligram in 24 hours. But our Indian patient will never need that much. All maximum I have used is 1800 milligram per day, or my colleagues also, because patient just cannot tolerate. So 1800 means 2 TDS, because each tablet is 300 milligram. Pregabalin comes in the strength like 75 milligrams, so you can use theoretically again 600 milligram per day in white race But in Asian population, I've never given more than 450, and they never tolerate more than 600 is not tolerated by Indian patients, right? So but BID is pregabalin has a linear pharmacokinetics. Always remember, but gabapentin has got a non-linear pharmacokinetics, so that you should remember. And gabapentin is given TTS, while pregabalin is administered BID. Always remember, okay? And there's no other route for gabapentin and pregabalin. It's only this one, right? And well, you can have other things, complementary and non-pharmacological methods like acupuncture and all those. Time doesn't permit me to talk about that. You also have cognitive behavioral therapy, right? CBT has got good results. We've used that. So those are the things. And you have also neurolytic procedures. I told you, neurolysis caused by alcohol, and we are giving it at the site of celiac plexus or superior hypogastric plexus, depending on the underlying condition, right? Okay, next one. But please remember, whenever you have given started gabapentin, pregabalin, good number of those patients, initial 3, 4, or 5 days will say that, I mean, it will be poor compliance. They may drop out. They may stop taking it, mainly because it causes giddiness and dizziness in the initial part, in the initial 3, 4 days. So patient must be told, otherwise they get a shock of the life that what kind of drug you had given me. Some of them, they read text books, and there it is written as anticonvulsant. And actually these drugs came as anticonvulsant, right? They were designed as anticonvulsant, but then, this researchers, I'm talking about 99 and 2000, when they realized that no, it has a very strong analgesic action, right? Why analgesic action? Because it has strong affinity for alpha-2 delta receptor located in the voltage-gated calcium channel. And, in chronic pain, there is an increased intraneuronal concentration of, excitatory neurotransmitters like glutamate and substance P, and calcium also. So because it has strong affinity for alpha-2 delta receptor, the pregabalin gabapentin, they stop the entry of calcium inside the neuron. So when the intraneuronal concentration of calcium goes down, you have a significant reduction in the release of excitatory neurotransmitters like glutamate, substance P, like that. That is how they control pain. Okay, bone pain, I have already told you, right? Either you have bisphosphonates, zoledronic acid in the beginning, or you have calcitonin, which I was telling you is an osteoclast inhibitor. Okay, all right. Next one, please. Quality palliative care, again coming back to that, you have relief pain, you have relief symptoms, there is a caregiver support, there is a social and spiritual support. So goal settings are there. So these are the typical characteristic of good quality palliative care. Next one, please. And you have the structural elements and the targeting of those with serious illness, and you have a kind of team approach, interdisciplinary, that kind of team-based care, and you're finding flexible levels of care delivery and all those kind of things which are there and delivered concurrently or independently of the disease treatment. As I said, either with chemotherapy or after chemotherapy, right? Sure. Next one. So you understand the need, the sickest and the 5% account for 50% of the expenses. Obviously. Okay, next one. And this is where you see who are the costliest 5% of patients. Those, where you see these are the one last 12 months of life, okay, and short term and persistent high and those kind of things. Yeah, next one, please. So I said those concentrated among those with functional limitation, dementia, serious illness. Those are important ones. Next one. The impact of palliative care on the value. Next one, please. So the value actually can be calculated as quality or oblique cost. Okay. Next one, please. And the impact of palliative care comes to the cost. Setting and treatment aligned with patient goals. And here it is written, reduces 9/11 calls, because in USA pattern, everyone is familiar with 9/11. Reduce unnecessary tests, procedures, and patients live longer, obviously, better family support. So family members are also happy, and it relieves the pain and symptoms, right? That's the biggest achievement. Okay, next one. Palliative care improves outcome, no doubt about it. Yes, next one, please. And you find that palliative care improves the outcome for family members also, naturally, not only for the patient, but for the family members also. Okay, dying in hospital associated with all those kind of increase, prolonged, and those kind of pain, and dying in an ICU associated with fivefold increased risk of post-traumatic stress. So those kind of things are there. All right, next one, please. And this is something like cost saving. I think we can skip, go to the next one. Palliative care reduces readmissions, no doubt about it, right? You can discharge them and they can go home. Domiciliary care, community services also can be incorporated under palliative care. Please remember that, right? And those kinds of, right. Next one, please. So this is where you see palliative care at home for the chronically ill patient, and this is where you find those kind of things are there, right? Home health visits shooting up, and in between you have palliative care intervention. Okay, all right. Palliative care growth, yes, it has gone much beyond your expectations, you find, right? And in US especially and UK, they are the leaders in establishment of palliative care services. Next one, please. I think we are almost coming to the end. The higher staffing results in palliative care, serving more patients. Yeah, next one, please. And you have the obviously there was, as I said, financial burdens and other burdens were there. So by giving palliative care services, I'm sure you can alleviate that. You can bring it down. Next one. So there are important 7 C's in palliative care. Please remember that. That should also be your take-home message. 7 C's include communication. Please remember that. Communication is very important in day-to-day practice, and same way in palliative care. Coordination. Okay, will you remember that? Then control of symptoms. As I said, we are controlling those symptoms: pain, breathlessness, right? Constipation, and those kind of things. Continuity is there. Am I right? Then you have continued learning also. Obviously, this continued learning applies mainly for doctors, but then even for the family members. Carer support, the carer, the healthcare workers are there, they are supporting. And last but not the least, as I said, bereavement or care of the dying. Care of the dying. So this communication, coordination, control, continuity, and carer support. And when I said continuity, then I also mean continued learning and care of the dying. So these 7 C's are very important whenever you're talking about palliative care. And also here, I would like to tell you something more. When I say there's a term used, 20% palliative. What does it mean? 20% palliative it means 20% totally bed-bound patients are there who are unable to do any activity because of the extensive disease. So remember, right? That's a tragedy. It may be 20% palliative or it may be 40% palliative, which means the same thing. 40% totally bed-bound patient. Okay, right. Next one, please. So you're meeting the growing needs, and as you can see here, all those kind of things, that everything, this is obviously the American data. We have no record of the Indian data, which is again in infancy in India, that it has got more than doubled, right? Its population and all these kind of things are there. And well, those age changes are always there, that those aged 65 and above are projected to account 20% of the population in US, and even in India, those 65 and above, the number and the percentage has gone high. Next one, please. So how do we meet the need? Again, by setting up more palliative care services and training clinicians, as Government of India is now doing. Next one. And thanks to Dr. Sangeeta's selection of this topic, again, I'm sure many of you again will get training, and they've already got sensitized to the concept of palliative care. Next one, please. And so you see, I think we can skip this one. If you really ask me, funding, I'm sure funding, obviously, that's the biggest constraint and the limitation. Even in US, there's a lot of cut in the funding. But then whatever we have to bring out some of the innovative ideas. As I said, when I'm giving a block with using absolute alcohol, uh, 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 intervention for celiac plexus neurolysis under CM, I'm bringing down the cost, let me tell you. And again, if you ask me, is the alcohol in supply? The alcohol, yes. In between, it was not there in supply, and I myself had to buy one bottle of 500 ml, that Mark 95% alcohol from Bhagirath place. There also it was costing 2,500. So all those things are there. There are limitations, but you have to find out some innovative way which is cost effective. There's something, this one you can see, this is what I was talking about, the buprenorphine transdermal patch, right? Very expensive, but then those who can afford, they can. And the best part is it has to be changed only at the end of the 7th day, right? 20 milligram, that 20 microgram hourly basis is very high dose. We need it only in advanced stages. Otherwise, usually 10 microgram hourly basis, that one is good. Okay, next one. Uh, yeah, this is the same Matrix technology. Okay. This is what I was talking about. This is one of the patient. She actually was a case of CA breast, and following mastectomy having been done, she was referred to me. She had chronic persistent post-surgical MRM neuropathic pain, which is again everything she said. She used to tell me my chest is burning, my that part, that half of the chest where the breast was removed. And this patient also had the sensation of phantom breast. Imagine when we cut a limb, say whether it's because of pathology or trauma, in the accident or railway accident, you find patients, many of them suffer from phantom limb pain. Similarly, here also, many of these women, they suffer from phantom breast, even if that breast has been removed and excised. And this is where we are giving radiofrequency therapy and intervention for management of pain. Next one, please. And yeah, this is again the same CRM and the radiofrequency machine which we have been using under CRM using contrast dye. Next one, please. And this was another lady who suffered from carcinoma of the lung, and here we had given intercostal block, and then we did radiofrequency after the diagnostic, then the radiofrequency lesioning of the intercostal nerve, and patient died in peace. That was almost within 6-7 months after the administration of this particular intervention, but patient died in peace. Next one, please. This is just a 9-year-old boy who had carcinoma of the scapula, and RF lesioning was done for the suprascapular nerve with great difficulty. That was very challenging. And this, though we lost this child to follow up, I don't know, but till 3 months he was coming to us and he was quite comfortable. Yeah, next one, please. So as I was telling you, with any patient, because the response to drugs, everything can vary, and the pharmacogenomics and that kind of genotypic phenotypic environment interaction is always there. So those kind of variations are always there, right? I mean, these patients are our masters and they are teaching us so many things, but you will not have a uniform response in each and every patient. Even if the staging is same, even if the condition is same, the pathology is same, even if the age and gender is same, you will always have a variation in response. Next one, please. So these are some of the one of the as I was telling you, one of the study we have conducted and published that for chronic persistent post-surgical pain. This was patient of CA ovary, and we did some genotypic studies, and we found that there was an upregulation and positive correlation between the mRNA expression of the signal transduction genes, which in this study we had used ERK, PKA, and PKC, and they had a close relationship with the VAS scoring. Next one. This particular one is very interesting one. BMC Palliative Care has got the best possible publication palliative care. Like this one is showing the trends in the treatment during the late stage of life and end stage gynecological cancer patient who received active palliative chemotherapy, right? And they had done a comparative analysis of the 10-year data, and they found that the frequency of palliative chemotherapy and invasive procedure at the end stage gynecological cancer, right? They were treated aggressively without hospice management. Because you don't have hospice facility everywhere. Even in India, if you talk to me, ask me in Delhi, there is no hospice. But one you find is kind of Shanti Avedna Ashram, which is next to Safdarjung. But that's also not a very typical hospice. right? So, but their usage has increased over the last 5 years compared to that in the past, and duration of from the last chemotherapy session to death has decreased, right? Okay, next one, please. This is where another one, you see, where they use an innovative technique, then outpatient telecom administration by, indwelling pleural catheter for malignant pleural effusion, right? Again, it was carcinoma, malignant pleural effusion. And this technique resulted in significantly higher chances of pleurodesis at 35 days than an indwelling catheter alone with no deleterious side effects, all right? So this is what they had done. 4 gram of talc was used through an indwelling pleural catheter for the treatment of malignant pleural effusion. Now, spirituality again, yes, yeah, access to palliative care for homeless. As I was saying, it's an important publication done by publication by Veer et al. Palliative care currently provided to people experiencing homelessness. As I said, those people who are poor and who are homeless, and you really feel bad that you can't provide them even those uh, basic drugs because they are unable to travel. Because I was like, we are working in a tertiary care center, and for patients to travel 200 or 400 kilometers is not an easy job for all of them. They're most of them are in farming, and they don't even have that much money to travel. Next one, please. Now, this particular one, you will see it's a team approach, as I was always repeating every time, and that it is always a team approach because only doctors cannot achieve that particular goal. Doctors, nurses, right, paramedics, your social workers, okay, and same way even those spiritual those patients those with high integrity and saintly people, right? So it is always a teamwork which actually brings you the results. Yeah, next one, please. And spirituality, this is a very interesting one which appeared only is wrongly written as 023. It is 2023. It plays an important role, and this particular article is that it is becoming clear that healthcare approach that mainly focuses on alleviating physical pain is no longer adequate. As I see the spiritual dimension here, and that responding to people with palliative care needs inevitably it requires engaging them with spiritual dimensions for each person, for each patient. Remember, okay. So we have come a long way in easing those physical discomfort, but then we have not come a long way in easing those, that kind of aberrations and behavioral disturbances which these patients suffer from, right? And that is why they have suicidal tendencies. So this is where spirituality plays an important role. And in alignment with the WHO statement that it is the ethical duty of the healthcare professional to alleviate not only the physical, but also the spiritual suffering. Next one, please. So this is important publication. Now you see this particular one is from, it is from actually from the city of Jaipur. You should be proud of the fact that this particular study from the city of Jaipur, and you see there's something like we always use the component DTL. DTL stands for desire to live, and these are the patients who have lost the desire to live. Always remember that. But there are patients who say, I want to live, but please provide me relief from this suffering, alleviate my pain. So those kind of things are there. A very beautifully conducted approach study which was there, and mainly she's actually Anjum Khan, right? And she did good work, right? And the conclusion drawn here was that if I say pain severity, psychological distress, and low socioeconomic status, they reduced the DTL, means desire to live. So imagine those with middle income and higher income, those people, they have a high degree of DTL, they want to live, but those low socioeconomic economic status, unfortunately, they say they have, very reduced desire to live because they can't afford. Perceiving oneself as poor actually reduce the probability of your desire to live. Limited access to palliative care in India, whatever we may say that we have brought out these services, that insurance, this and that, but it will not be sufficient, right? Especially for patients from the low socioeconomic status. So it's a good publication. I must appreciate that. Next one, please. Almost the last one. And so now you can answer what is palliative care, I'm sure. having been told the definition, and I'm sure now you can tell me what are the goals of palliative care. You can tell me what are the principles of palliative care. You can even tell me what are the stages of palliative care. Am I right? You know, and you can also tell me what are the 7 C's of palliative care. And you can also tell me what are the main drugs which are used in palliative care for pain, drugs used for breathlessness, drugs used for anxiety and depression, and drugs used for delirium and agitation. Last but not the least, delirium and agitation in patients in palliative care, where I was telling you, you have haloperidol or midazolam with haloperidol, or midazolam with your what you call it as levomepramazine. Levomepramazine. You have chlorpromazine. Similarly, you have levomepramazine. You can combine with midazolam, and if everything fails, I'm sure you can use your oldest possible drug, that is phenobarbital. All right. So the next one, please. Right. I think I hope I have been able to simplify my talk. I know it's a very lengthy topic, and just in limited duration, I've still skipped many, like I was telling you, those questionnaires and all those kind of things. And so you have your homework, and I'm sure persons like John J. Monica and Dame Cicely Saunders and Albert Einstein will be a very strong source of inspiration for all of you. So thanks very much indeed for your kind attention, please. Thank you. Thanks very much again, Dr. Sangeeta Sharma and Dr. Srivastav, sir. Thank you so much. Thanks for your invitation. Thank you.
Thank you, sir, for such a lucid, making it simplified. Earlier, when this topic was selected, given, by Dr. Srivastav, I was wondering, what will we do internally ill patients, and because we have people coming from all levels of healthcare, including some people from primary healthcare to tertiary care. So how will we navigate this topic? This is, because it has components, which are dealt at a higher level. But I think you've done a wonderful job
Thank you
of,
so
I think some of the participants can take home some of the messages, and I feel now my presentation is redundant.
much. No, not at all.
You have already addressed,
No, please.
maybe, are you going to stay back, or
Yeah,
we can take the questions?
very much available. Yeah.
Maybe I can, shall I show you the questionnaire? Because I had made
Yeah.
a pre-test around these things only. So I think once we see that, the responses, then we'll understand. Let me just share.
But it was a great session. My camera is not working, but
Thank you so much.
I've been listening all through.
Thank you so
And
much.
really, you have, such a complex subject. You have explained it so beautifully. And really grateful. Most of the questions pertains to the grading of the pains and other thing, either today or some other time you can.
Anytime, sir. Should I?
Yes, if you can quickly take that,
Yeah.
till the time I'm loading this, you can do that.
Sir, if I correctly get it, you were asking about the grading of pain. Am I
Yeah,
right?
yes, like 1 to 10, what you explained.
Right.
So many participants had put that question in the chat box.
Okay, sir. Thank you for the opportunity, sir. Sir, it is. Let me simplify this thing, because let us remember that pain is a subjective sensation. Unfortunately, like thermometer can assess the accurate figure of the temperature, but we don't have painometer. That's the biggest setback, though a lot of research is going on. It is a subjective sensation, we all know that. So we really have to believe in what patient is saying. There are certain prisoners who are coming from, say, for assessment and for therapeutics, from Tihar jail or Mandoli jail to us, and the rule of the the rule of the land and the guidelines are, even if they are pretending to be in pain, you have to treat them, because you really don't know whether they are really in pain or they are not in pain. But we may be thinking by experience, oh, he is trying to pretend, but even then you have to treat him at every cost. So that's one thing very important. The other thing which is there, that, as I said, sir, there can be, first we have to know whether it is nociceptive pain, which nowadays we are calling as nociplastic, or is it a neuropathic pain? Now I'll give you example like neuropathic pain, typically 100%, that is like post-herpetic neuralgia following herpes zoster. Like I'm sure people would have seen this particular ad, which is a beautiful ad, which is appearing by Amitabh Bachchan on the new vaccine which has come for herpes zoster, the shingles, they call it as shingles, because it is really, sir, those patients of I'll tell you, those patients of herpetic neuralgia, they come in such a large number to GTB hospital, and obviously it is this vaccination everyone cannot afford, and it is very painful also. In West also they have started this vaccine for herpes zoster just about uh, 4 or 5 years back, not before that. So the incidence of herpes zoster in West has come down, is coming down, not that it has really significantly come down, but in India it is still very high. And I tell you, give you one example, another one, that we I know I myself had this kind of presentation where one of my colleague, he actually complained of low back pain, and he got himself treated by an orthopedician. An orthopedician had written down few medication you take and you should be all right, not to worry. But then the pain continued, and what happened actually, without blaming anyone, the orthopedician had not done a detailed examination. At his back, the herpetic lesions were there, which obviously the patient could not see, and the orthopedician had not examined. So what I mean to say is that a detailed assessment, even if of course you have to undress a patient, you should not hesitate, because examination is very important. And same thing happened with me when I went to Vrindavan, and one of the Mataji was having this particular problem of herpetic neuralgia. So anyway, coming to that side, sir, when patient has stabbing and burning sensation, it is typically neuropathic in nature. Similarly, diabetic neuropathy, when the distal part of the extremities, for long standing, after having suffered from diabetes for 4, 5, or 6 years, they'll end up with diabetic neuropathy. So diabetic neuropathy and post-herpetic neuralgia are typical examples of 100% neuropathic pain. But in cancer pain, just 1/3 or maybe 40% of the component would be neuropathic, as I said, and 1/3 would be around nociceptive, and 1/3 will be mixed type. Now, neuropathic pain happens mainly because of peripheral sensitization and central sensitization phenomena happening in the central nervous system. There's a kind of augmented response, bizarre response, and a kind of wind up phenomena which is actually happening in the central nervous system, including the dorsal horn of the spinal cord, where you find that even the microglia and the astrocyte are also involved in neuropathic pain. So neuropathic pain is actually a real event when you really should be able to diagnose, and with the help of, as I said, one is DN4 questionnaire, or you have pain detect questionnaire, or you have neuropathic pain symptom inventory. Again, based on those kind of things like burning, stabbing, pressure-like effect, lancinating effect, and those herpes I was talking about, where many of the patients will say they will prefer to remain without banyan, because when it is thoracic dermatome and when they wear banyan, there is always a friction, and the pain was increasing like anything. And then about the assessment, sir, the simplest and best possible is NRS, we call it as 0 to 10. And 0 means no pain, 10 means the worst possible pain that you can imagine. And so we ask, like many of them may be illiterate and uneducated. Then you say you use the formula of 100 paisa. Out of 100 paisa and 1 rupee, then we have a scale. We have written 50 paisa, 10 paisa, 20 paisa, 100 paisa. Then we'll ask the patient ki bhai, aapka pain 100 paisa out of 100 paisa, which is unimaginable, or aapka jo hai pain is 50 paisa out of 100 paisa. So if they put it on 50, then we take it as 5 by 10. If they put it on, say, 75 or 80 paisa out of 100, then we take it as 8 by 10. So, if patient has 1 by 10, 2 by 10, we can always ignore it. That's again very mild pain. But if patient has something like 3 out of 10, 4 out of 10, 5 out of 10, then we call it as moderate intensity pain, sir. And if patient has that 60 paisa, or 70 paisa, or 80 paisa, we call it as, or 90 paisa, we call it as severe pain, sir. And if it is 10 by 10, then we call it as typical excruciating pain lasting obviously maybe for weeks and months together, and patient may be highly frustrated and, as I said, highly irritable also, and with maybe possibly suicidal tendencies. So those are the things which I hope that it is okay, sir. Otherwise, I can go.
Explain them. I mean, fully understood. Thank you. Thanks so much.
Thank you so much, sir. Thank you, sir. Thank you.
I think you can see the questionnaire. First two were just eliciting the opinion or the whatever challenges they faced. But this question was about palliative care is synonymous with end of life care. I think it was half and half. Now I think people are clear about this. This can happen. Palliative care can happen anytime. Need not necessarily be at the terminal end of the life here. So it is not same as end of life. What is the fundamental principle of palliative care? I think he has again and again pointed out towards the holistic care here, not only the doctor looking after the curative part, but also the other part, addressing physical, emotional, and spiritual needs of the patient. Although the participants, 81% also believed that, so that's a good thing. What does the principle of shared decision making in palliative care emphasize? Although I think 90% around people are saying that it involves families in healthcare decisions, but I don't know how much practically this is happening. I think there is a gap here, knowing gap between what we know and what we do in practice, and I find people, कि उनको समझ नहीं आएगा, how do we explain, it's difficult to engage with the patient about the terminal care, or that their end is approaching, or the pain will not be relieved. So these are difficult situations,
Right.
and I believe then yes. What is the primary goal of pain management in terminally ill patient?
Right.
I think the response, we are not trying to achieve 100% pain relief here. So our aim is to make it tolerable for the patient. So Dr. Saxena was talking about law of expectations. So you have to manage the expectation of the patient here. We need not, promise them that it will 100% relieve their pain, but we are trying to make it to the tolerable level. What is the role of adjuvant medication in patient pain management for terminally ill patients? I think enhancing the effect of adjuvant and addressing specific pain mechanisms. I think the responses, now you've got the answer. Primary analgesics may not be of help in severe pain.
Right.
The pain score is about 7, 8, 9, or 10. They'll not help. So maybe we'll have to enhance the opioid. And one thing even I also learned today is oral morphine, there is no upper dose limit.
Yeah, that's right. Yeah.
So I think Dr. Saxena, I had a few questions which we will take. Switching, when you said you will start with the IV if patient is having severe pain. You start with IV, and then ultimately aim should be to switch to oral.
Oh yes, absolutely, ma'am. Absolutely. Because that's
but I think the problem comes, when you want to calculate the dose orally, IV, and how do you calculate that?
Yeah, no problem with that. I'll tell you. See, ma'am, there are very clear-cut formula we need to know, because opioid receptors, as you know, everyone knows, and you are a master, they are located in the dorsal horn of the spinal cord, right? Mainly, and then higher up in the central nervous system. So if I'm giving any particular morphine which is going into the subarachnoid space, and it is very easily going onto the dorsal horn of the spinal cord. So if I'm adopting that route, then I need to give only 1 milligram morphine, and that 1 milligram morphine in the subarachnoid space, which I have injected will be equal to almost 5 milligram, which is given in the epidural space. That means the one which is next to that. Now this particular one, 5, and this will be equal to 10 milligram of oral morphine. So imagine, on one hand you are giving 1 milligram, and over there this 10 milligram, almost 10 times, which is there. That is the oral equivalence of that. So this is the bioequivalence formula that you find. That is how it operates, right?
I see. Yeah. Another problem is,
Huh.
yeah, please.
Yeah,
Please carry on.
yeah.
Another problem is that, if, for example, fentanyl to morphine switch.
Right. Oh, that is something where we have to be careful, because on one hand we don't have transdermal patches of morphine. We have only transdermal patches of fentanyl, right? So your question is relating to that patient was on oral morphine and you are making switch over to fentanyl patches. All right. Is this the question, ma'am? I don't know.
Yeah, either way, patient on morphine, you
Right.
need an extended release preparation for a
Right.
longer duration pain relief.
Exactly. So it comes to the point that where supposing patient was already receiving 40 milligram in 24 hours, or patient was receiving 60 milligram in 24 hours, maybe let us say maybe 90 milligram in 24 hours. Now that particular case I take where patient was receiving 90 to 100 milligram of morphine in 24 hours. Now this will be can be easily managed with transdermal fentanyl at the rate of 50 microgram on an hourly basis, ma'am. But we should not forget that when I apply the patch in the initial state, the onset of action starts 12 hours after the application of the transdermal patch, madam. That means if I've stopped morphine here, now I have applied the patch, I must understand that that particular intervening period of 12 to 18 hours or 24 hours, I must continue with either intravenous morphine or with an extra dose of oral morphine, like that. So it is very clear cut, formula where I use 50 microgram of either fentanyl, which is being released on an hourly basis, or I use is either 10 or 20 microgram on an hourly basis of buprenorphine patch. And on other hand, patient was receiving either 60 or 90 milligram of morphine on 24-hour basis. It's like that, man. Yeah.
Thank you. This is one very important take home. Don't expect that immediately after applying the transdermal patch,
it takes 12 hours.
There is a lag period of 12 hours. So you have to.
This comparison I have mentioned for oral morphine versus transdermal patches. I have not compared the subarachnoid or intrathecal administration of morphine, because that's a single shot, because you can't give it repeatedly. Epidural you can give top up, but then we have to be very careful. In oral, I was saying no question and no possibility of respiratory depression. But when you're giving intrathecal morphine, ma'am, because it is hydrophilic in nature, so it can go right up to the thoracic level, from lumbar to thoracic to cervical level. So chances of respiratory depression are quite high, and even as late as 18 hours after the administration. So there one has to be very careful. That's possible.
I think, yeah, very good. Thank you, sir. Then this question, I think, was also answered by Dr. Saxena. The most often barrier mentioned for appropriate use of opioids in pain management is the fear of opioid addiction. But I think he has made it amply clear that addiction does not happen if it is being used for pain. Addiction happens because of the misuse. Can you elaborate on this further, sir?
Yeah, ma'am, I'll tell you. I'll give you one example starting from tramadol. Tramadol is a weak opioid, and they have done especially the German study which is there, because tramadol, we say it has got two modes of action. One is it has got mu opioid receptor affinity action, that is one, and the other one is that serotonin norepinephrine reuptake inhibition. So those two mechanisms are there. It has got dual mechanism, as you know it very well. They have seen that following administration of tramadol in about, I should say rather, almost 80 to 90,000 or even 1 lakh. When 1 lakh patients are administered tramadol on a regular basis, it is just 1 to 2 persons out of 1 lakh who actually develop kind of physical dependence. So these are the figures, madam, for tramadol. Just 1 to 2 develop physical dependence out of 1 lakh patients who have been administered. With morphine, it is again coming to the same level, that just 1 to 2 out of 1 lakh. And they actually say it is a kind of physical dependence, but they have never seen anything going wrong, because patient was suffering from that persistence of pain of a high degree level. That means either severe or excruciating kind of pain, ma'am. So these are the figures which are there, ma'am.
Thank you. Next is, can you prescribe opioids through a repeat method?
Oh yes, repeat which particular route you are talking about?
No, here I meant actually, many a times in regular clinical practice, we say continue same treatment.
Oh yes.
But with
I
that
tell
is
you,
not allowed with,
I
that is not allowed.
I know, no. That means, say, if I get your question correctly, that means today if I have prescribed oral morphine at the rate of say around 10 milligrams 6 hourly, that means I have given him 4 tablets per day, and I have given him a quota of say, because I don't give it to them, we don't have that much stock for more than 15 days. That means 60 tablets I have given to him. Now he comes back again after 15 days, and his pain is now well under control. I would say it is around 4 by 10 or 5 by 10, which was initially 9 by 10. So I repeat it. But if he continues to have 7 by 10 or 8 by 10, is not satisfied, pain is on the high side, I will increase it further. So I am actually continuing. Yeah. And I have continued it for months together. Yeah.
No, but here I wanted to point out,
Uh-huh.
make it clear that you just can't say continue same treatment, continue. Some kind of reassessment is there
Oh,
every
yes.
time that you
Absolutely.
are making an assessment and then writing a prescription again.
Right.
Because
You're
with
absolutely correct.
opioids, this is one of the regulatory
Yeah,
requirements.
you're right. We call it as titration, actually.
Yeah.
Yeah. Assessment.
So it
Titration.
has to be ink.
Yeah.
It can't be photocopied and
No,
given to the
not at all,
patient.
ma'am. We have to rewrite. And we also have to write that in last 15 days, what was the frequency of constipation? What was the frequency of pruritus? We have to write everything, ma'am. Yeah, you're absolutely correct. Yeah.
Then, what is the key aspect of principle of effective communication in palliative care? I think we know it, open and honest communication. Most of you have got it right.
Yeah.
Is it acceptable to share opioid medications with family members if they are experiencing pain?
Always, ma'am, always. In fact, it is not that it is written in black and white, but our etiquettes require that we must tell them, because tomorrow, if whatever has been dispensed to them, and then they come in contact with some educated fellow or in the internet, or they go to a chemist, and that fellow may say, oh, what kind of drug they are making you an addict and all that. So we must always share it with the relatives. Always, ma'am. Yeah.
No, they're sharing here without a prescription, on their own, a person in the family is taking a medicine, on opioid medicine. Somebody else also in the,
Oh,
it's like,
I thought sharing of the information.
no,
No.
it's a
No,
sharing of the medication.
no,
With,
not at all, ma'am. We, in fact, we are very clear about it. And of course, not that we are all the time present in the house of that particular patient, but we somehow, we don't have a very strong case of judgment that yes, we can't say that someone else won't have taken, but we take it for granted that patient has been taking, ma'am. Yeah. I mean, you have to have that much faith. I know we don't have any other method, because patient is not there in the ward and patient is going home, and we really have to believe. We even ask them for empty foils, empty wrappers, but then there is no other way out, madam, that
I
It is,
know, we need to believe the patient,
yes,
but this is one of the requirements
it
of
is
a
limited. Yeah,
responsible opioid prescribing.
absolutely.
Because
Right.
you need to look into it. The patient is not misusing or
Yeah,
is not. Otherwise, morphine is, as he's been repeatedly saying, is a very very good analgesic
yeah,
agent, because the misuse happens in these ways. So these
it
should be
is.
avoided.
Yeah, you're absolutely correct. Yeah, yeah, that's right. Bilkul. Yeah.
Okay. Then unused opioid medications can be safely disposed of in the household trash.
Right.
Although the
Yeah.
safely, you cannot just dump it into
No.
the trash.
Huh.
You have to
Yes.
secure, make it a seal, remove the any information about this, and transdermal patches should not be tampered with,
Yeah.
but with adhesive side touching it, you have to fold it and then secure seal and then dump into. Otherwise,
Ah,
because the innocent rat pickers or animals
yes.
can
You, you're
eat
absolutely.
on this.
Yeah, it's important. It's important. One has to follow these guidelines. Yeah.
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 So disposal has to be done properly.
Hmm.
And opioid, we know that it has a misuse, but addiction
Oh,
potential also.
yes.
Now, I think that directly now coming to which of the following is not a common reason for the failure of pain management in terminally ill patients despite opioid therapy. Uh, Underestimation of pain severity, reluctance to escalate opioid doses appropriately, opioid tolerance, fear of opioid addiction, and last one was rapid elimination of opioids from the body. I think now the answer is very clear.
Hmm.
Many a times we underestimate pain severity.
Absolutely
We
correct.
are we are reluctant to increase the dose of opioids, and you have to respond to the patient's
Yes.
level of tolerance here. Opioid tolerance does happen. This is a pharmacological
Yeah.
phenomena that
Yeah.
happens over a period of time. That to maintain the same effect, you need to increase the dose of the drug.
Right.
And as he said, opioids, there is no upper limit. You can go on
Right.
increasing. So you need not worry about the opioid tolerance. But if it
Yeah.
is a big problem, he has told you you can switch to methadone, any other fresh options of opioid, so
Yeah.
that the effect is returned here. I
That's
hope you've got that lesson here. Opioid addiction has been so elimination is not a concern here. So
yeah.
either there is something wrong with the pain estimation, or your evaluation or evaluation. Rest all can be managed. Then this is a 65-year-old cancer patient with metastatic bone pain, is experiencing severe pain despite having round-the-clock opioid therapy. What would be the most appropriate next step here? Again, I think the answer was very clear. Reassess the pain and
Hmm.
increase the current dose.
Yeah.
So don't need to switch to others if it is possible. I
Uh,
think,
you
would you
know,
like to add anything
no,
here?
yeah, yeah, yeah. Sorry for the interruption. I think in bone pain, madam, because of metastasis, we may
Hmm.
have to use certain, we may have to add adjuvant.
Okay.
And the
Okay.
most important one, as I said, is zoledronic acid, which is
Okay.
available in our Indian setup. But keeping aside those side effects, the important one, osteonecrosis of the jaw. And in late stages, we may use osteoclast inhibitor, those kind of
Okay.
calcitonin.
Okay.
Yeah.
Okay,
Yeah.
good. Then this is a 50-year-old patient with advanced lung cancer receiving palliative care. Neuropathic pain is there, but is not adequately controlled with opioids alone. What adjuvant medication is commonly used for neuropathic pain in this
Yeah.
setting? I think, again, maybe you can highlight.
Yeah, gabapentin and those things. Yeah, that's it.
Then a 78-year-old patient with end-stage heart failure is experiencing dyspnea. I think you also discussed
Right.
this dyspnea. I don't have midazolam here as one of the choices, but
No
next
problem.
time I'll put
Well,
midazolam as a
it's a good option.
choice.
It's a
But
good option. Yeah, yeah. definitely.
So opioids is the correct answer.
Definitely.
NSAIDs will lead to fluid retention, so they
Oh,
are
yeah.
not the good option here.
Yeah.
Okay, benzodiazepines, maybe we could have specified midazolam here.
Yeah.
Diuretics, the correct choice is opioids here. A 60-year-old patient with advanced pancreatic cancer is receiving palliative care, and he is suffering from opioid-induced constipation. Again, lifestyle modification, diet modification, fluid intake, laxatives, stool softeners for prevention of this remain the mainstay of treatment.
Yeah.
Because we don't have that many drugs for relieving pain, constipation
Right.
due to these opioids. So these remain the mainstay. So there is no need to, many times you may not be able to reduce the dose or stop the drug causing
Right.
constipation because they are required for the pain relief. So all these changes would be needed. Then a dementia patient, advanced dementia is experiencing agitation and distress. The primary goal is to provide comfort and improve quality of life. What non-pharmacological approach is recommended for managing behavioral symptoms in dementia patient? I think I forgot to mark this, but physical restraints are not advocated, should not be done. Benzodiazepines may have problem of sedation here because the patient is already having advanced dementia, so may not be the good choice. But antipsychotic medication can be, good option for controlling the agitation of this patient. But the question said non-pharmacological, then you have to look at the environmental modification. So medications are not the only way of managing. So
And
you
not
have
only even those acupuncture and acupressure again,
yes.
they can play
So,
good here. Yeah.
so just don't depend on the medication. Look at the other supplemental ways of pain management.
Yeah. Yeah.
Okay, then, this is a patient of chronic pain, has developed opioid tolerance, requiring escalating doses for the same level of pain relief. What is the most appropriate action in managing opioid tolerance?
Right.
Rotation can be done, or you can go on increasing the dose.
I think
that
rotation is a good option. Definitely. Yeah. Yeah.
Okay, so both A and B will do. I think this is an 80-year-old patient with end-stage renal disease, is experiencing moderate to severe pain. The patient's renal function limits the use of certain analgesics. What pain management approach is most suitable for this? Here, most of these morphine, oxycodone, tramadol, they are excreted by the renal route, and
Yeah.
they are converted into active metabolites. They are also excreted by the renal route.
Right.
So mild to moderate renal impairment may not have to adjust,
Exactly.
but severe renal impairment, you need to adjust the dose.
Right.
So dose reduction is most of the time advocated,
Right.
and you have to use these with cautions, with dose adjustments based on the renal function. Otherwise, fentanyl is the good option.
Is a good option. Yeah, that's right.
For severe renal impairment, fentanyl is the good. Oxycodone is not available in India,
Yeah,
so fentanyl is available, so you can use that. Next question is about because these terminally ill patient will also have other end organ problems, impairments. So you will very often you will find they have liver and renal impairment. So this patient is with liver metastasis, is suffering from severe pain. Given the hepatic impairment, which opioid should be used with caution to avoid potential toxicity? Again, you have to look at what is the route of metabolism. Liver is whether they are liver metabolized in the liver. So if the liver reserve is poor, so again you need to reduce the dose, or you have to choose a drug which is not eliminated by the same route. So that is the general principle for all drugs. If it is metabolized in the liver, then you have to choose a drug which can be metabolized and excreted by the other organ. So here codeine, again, you have to use with caution because ADR would be more, because it is mainly the liver, this thing. Again, morphine, fentanyl is a good choice, I think, again, for the patient with the liver impairment.
It is a good choice.
Although it is also metabolized in the liver, but the extent of metabolism of fentanyl is not much. So we don't expect much changes in the dosage requirement for fentanyl here. Last is about the transdermal patch for pain management. What is the critical consideration for the proper application of the transdermal patch? Here, if you're using it, what should be the advice to the patient? Here, you have to look at the site. Rotation of the site is very important. You don't have to apply this patch at the same location every time, and at least this should be rotated in a week's time. Of course, then you have to press it properly, apply it properly, and you can place it directly over the joint to target pain more effectively. Is that, how about this?
I just, sorry for the interruption, ma'am. The thing is that normally we apply it either in the upper part of the chest or in the upper arm, right? These are the usual locations, because it ultimately goes into the systemic absorption, right? So if you are applying it over the joint, then that doesn't mean, because ultimately it is the systemic absorption of the whole drug which is there. It is just that the route is different. And the second thing which I have seen, ma'am, at least in our Indian preparations, though they are not bad, but then when patient is taking a bath, many times it comes out. So we always tend to apply a micropore over that, on top of that, a waterproof micropore. Yeah. So it has to be secured, that particular, although they are it has a strong adhesiveness, but even then we apply a micropore over there on top of that. So that when patient is taking a bath.
I have seen many patients applying over the joint, actually.
That's a misconception, ma'am. Because only thing which I would suggest for that is a lidocaine patch. We also now in India we have lidocaine patch also, ma'am. Right. That I have not talked about it, because that is mainly for the nociceptive pain. But in cancer pain also there may be a trigger point. Now, when there is a trigger point, on top of that trigger point which is there, which is sending those discharges and firing all the time, over there we can apply, whether it is a joint or this. So lidocaine, 5% lidocaine patch, yes, you can apply on that particular top of the joint or this. But the problem with lidocaine patch, you'll find that it is recommended you change every 24 hours. You can change it after 12 hours also, because it works only in the initial 12 hours. After that, it doesn't work. The whole thing is absorbed. So lidocaine patch, yes, on top of the joint or on top of this thing. And second one is capsaicin patch, ma'am. There is an 8% capsaicin patch, which is actually not available in India, mainly in Europe or in US. Somehow we call it as a plaster, that those herpetic lesions on the chest or on thoracic dermatome, and you apply on top of that, right? So capsaicin, because capsaicin desensitizes the release of neurotransmitters which are being released. So capsaicin and lidocaine you can apply at the affected site, but for these you can apply any part of the body. The buprenorphine or fentanyl patches. Yeah.
I think if you have any question, you can write in the chat box. We'll be happy to take it. There is a question, sir, about whether patient's family should know about use of morphine by their patient.
Very important. They should know. Very important, because indirectly then it becomes their responsibility that that particular tablet morphine is not being misused by any other family member, number one. Number two is that, then they will not be able to put, although we always take a written consent, but they will not be able to blame the doctor that, this particular constipation got aggravated or pruritus is there, and you have, that misconception, relative may say you have made my son or my daughter as an addict. So it's very important that relatives and the family should be informed. Yeah, definitely.
So you mentioned about the consent. Is this implied consent or a written consent?
Ma'am, it is simply on the OPD paper, nothing very great. We take a very good written informed consent when patient is in the operation theater for the pain intervention, because then we have to tell them what are the side effects and complication of that particular nerve block. But here we take a very simple kind of consent. Of course, we take their signature, but then it's a it's a not a very well written consent, but then we always tell them these 2-3 important side effects of oral morphine. Yeah.
Any other question you have? There is a post-test link in the chat box. You can click on that and start attempting. And I hope all your questions have been answered. I don't know how many of you are directly involved with this, palliative care, or how many of you are directly dealing with these patients who need opioids. Let me see. Let me see the distribution of people. We mostly have people from all levels of healthcare. Mostly are doctors.
Right.
We have few nurses also with us. So I think this is a very pertinent topic for them also.
In fact, if they're there,
wonderful, sir.
I would just take another 30 seconds that we should always have that particular objective of training at least 2-3 nurses designated as pain nurse, because this is a new concept which is coming. And of course, in West, for chronic pain and cancer pain, they have typical pain nurse who is there, who is taught and trained in assessment of pain. She uses those scales and questionnaires. Like I will give you an example of Gangaram Hospital. Yes, they have few dedicated pain nurses, and so it would be very nice not only for chronic and cancer pain but also for post-operative pain following surgery. Because pain is the fifth vital sign. I forgot to say, because these nurses always monitor the pulse, the blood pressure, the respiratory rate, and temperature, these 4 things. The fifth one is pain as the fifth vital sign. So then once they are trained, they can have the column for pain assessment also.
Sir, when you say training of the nurses, what particular specific aspect you would like them to be trained about?
I think 2-3 things are there. One is they need to be sensitized about what actually, as you said in the background, what exactly they understand by pain, and little bit about the nociceptive and neuropathic pain. And then finally, the important job for them is the assessment, their regular assessment in the post-operative period or even otherwise when the doctor is busy. And the fourth one is that they should also know a little bit about the dosages that they are administering, and the things are well documented, but they should know that what drug they are pushing intravenously or what drug they are dispensing to the patient for oral consumption. So a little bit about that. So ultimately it boils down to the same kind of things which they are dealing with patient, and so they need to be trained in that direction. That's the thing. Yeah.
I think I'd like to add, this is about the clinical part. They are the custodians of these, drugs also.
Oh, yes. Yeah.
And these are controlled drugs, so they have to be kept in safe custody.
Yes.
And particularly important is having these enough stocks in the OR,
Yeah.
operation theaters. Many times it happens, आपने mention किया था कि वो supply discontinue
Yes.
हो गया या रात को you forgot to take out enough
Yeah.
ampules out and you need it for your patient.
Right.
So enough stocks should be maintained round
Uninterrupted
the
supply,
clock.
yes, is very important. Yes, absolutely.
Despite I know the sister in charge is the ultimate responsible for the custody, but round the clock it should be made. Arrangement should be there.
Yeah.
And one thing I would like to tell the nursing and other doctors here is pilferage. You need to check
Yeah.
on the pilferage,
Very
and
important.
it is our own staff who gets addicted to this.
Yeah.
Own staff who will pilferage
Yeah.
these drugs. So you have to have a very strong protocols
Right.
for management of stocks of these drugs.
Absolutely correct.
Link is there already in the chat box. Please start attempting. I think we had a very good discussion. मैं तो सोच रही थी सर क्या आप बात करेंगे? It's such a vast.
It was wonderful, sir.
Very good initiative you have taken, and I was told it is number 7 in the serial number. So hats off to you. You really have been taking a lot of pains. Great.
This is the second year. We successfully
Oh,
completed first year,
congratulations.
12 sessions. This is the 5th session of this year.
Achha.
I hope people like it. They are getting benefit out of it.
Is it
You
the
know, that's
fifth
the
one or
motivation behind
or
it.
the first one in 24? In 2024, is it the first
Oh,
one?
yes. Yeah, that's very right.
The first.
2024 का पहला session
First.
है, sir.
Yeah.
Okay.
That's
Ma'am, shall I close it, ma'am?
I think you can just ask them. They have opened the link for the post test. Please remember, those who complete pre and post test only will get the certificate. So please, and feedback. Because that tells us, how the session was. You can also give your suggestions for future topics so that we can select those. So please remember that you have to do both pre and post. फिर बाद में email लिखते हैं कि हमारे को मिला नहीं certificate. It will be uploaded on the YouTube channel. Annapurna, you can post the YouTube channel as well.
Yes, ma'am.
here.
I'm sharing the link for the YouTube channel also, ma'am. Under the
Nagaland
quality and patient
is
safety division.
okay. Mizoram, ठीक है. I'll add Nagaland in there. Okay, good. Thank you.
Thank you. Thank you.
Thank you, sir. On behalf of NHSRC, I thank Dr. Ashok Kumar, sir, and
Thank
also Dr. Sangeeta Sharma, ma'am, for conducting this session and sharing your valuable knowledge on the pain management in the terminal care and discussing about the queries for the participants and all. And also, I thank Dr. Jain Srivastava, sir, Quality and Patient Safety Division Advisor, NHSRC. And also, I thank Major General Professor Atul Kotwal, sir, Executive Director, NHSRC, for the continual support. Most important, our participants, we thank all the participants for the continual support and making these sessions successful since 1.5 years. This is continuously 17th session we are conducting today since 1.5 years, sir. And our next session is on February 17th. We'll be conducting on the topic of the skin infections. We will meet on the 17th February for the next month. And your certificate of participation will be getting another 5 days who is attended for the pre and post test in this session. And you can access complete session of this day in the YouTube channel under the name of the Quality and Patient Safety Division. Thank you, ma'am. Thank you, sir. Thank you once again for
Thank
all
you,
the
sir, for sharing your valuable time and sharing your
Yeah.
experience.
Thanks for the privilege, man. Thank you.
Thank you, sir.
Thank you,
Thanks
ma'am.
so much. Thanks,
Thank
Annapurna, for conducting.
Thank you, sir.
Thank you.
Thank you.
Thank you so much. Thank you.
We can close, Annapurna. They must have opened it. Let me check how many of them have attempted.
So, ma'am, we will leave another 5 minutes so that they
Yeah.
can attend.
अभी 39 ने किया है.
We'll leave for another 5 minutes, ma'am, so that they can attend it.
हाँ ठीक है.
हाँ, ma'am.
I've shared editable links also. Annapurna?
Yes, ma'am.
I've shared editable links also.
Sure, ma'am. Sure, ma'am.
Okay. You have
Okay,
a
ma'am.
feedback form is the same. You
Yes,
already
ma'am.
have that. Okay.
Yes, ma'am.
I can leave now.
Yes, ma'am, you can. सेवनटीन 35 को खत्म कर देना और 3 मिनट के बाद
तो होता जाएगा.
यार फीडबैक के लिए उसको लिंक चाहिए तो ठीक है, मैं और एक बार करके छोड़ रही हूँ.
वो तो भेजते रहेंगे दोस्तों.
हाँ, उसको लिंक तो चाहिए होगा ना. और 2 मिनट तो है, मैं लीव कर रही हूँ. ठीक है, लेट देम एंटर. दो लोग क्यों आए आप आज? किशोर आप
बुला लेते हैं.